Good morning. Welcome back to Open Med School. Today I am going to discuss with you about an approach to a patient with edema. Edema is a very common thing. So, edema can be in the peripheral, that is the distal part in the legs, or in specific situations like pulmonary edema and ascites, they are also part of the edema. Now, when you think about edema, this is that usually comes to your mind. Somebody has got a edema in the legs which pits on pressure. It is called pitting edema. Sometimes edema can be unilateral like this. So we'll go into the details of the mechanism of formation of edema, then the definition of edema. Edema by definition is excessive accumulation of fluid in the interstitial space. So that is edema. And edema usually becomes apparent when the interstitial volume increases by 2.5 to 3 liters. So the patient usually experiences weight gain before the development of edema. Keep this in mind. So before going into the pathophysiology of edema, let us look into the fluid compartment. So we have already mentioned that edema is an increase in the interstitial fluid, accumulates in the interstitial space. So this is a total body water is approximately 0.6 into weight. So total body water is 50 to 80% of the body's weight. So intracellular fluid is 2/3 and 1/3 is extracellular. Extracellular is divided into intravascular, that is in the blood vessels, it is 1/4, and interstitial space 3/4. So of the 1/3, we divide them into intravascular fluid and the interstitial fluid. Interstitial fluid is 3/4 of the extracellular fluid. Hope this is clear to you. So this accumulation in the interstitial space is called the edema. So what are the main driving force? The main driving force is the Starling's law of fluid balance. So there is a gradient of hydrostatic pressure and gradient of colloid osmotic pressure. So these are the two things. That is, the hydrostatic pressure inside the blood vessel will try to push the fluid outside, and the colloid osmotic pressure will try to absorb or maintain the fluid in the compartment. So the gradient is there because there is some amount of pressure inside the interstitial space also. So this is the pressure that pushes the fluid outside, and the gradient of the colloid osmotic pressure absorbs the fluid. Whatever is remaining in the interstitial space will be moving via the lymphatics. Hope this point is clear. That is the pressure, osmotic pressure, and the hydrostatic pressure. That is what is maintaining the fluid inside the various fluid compartments. So now we are going to what we have already said, that is the capillary hydrostatic pressure pushes the fluid outside. The interstitial hydrostatic pressure pushes the fluid in. Usually it is very low. So the gradient is the one that determines. The same way, capillary osmotic pressure pulls the fluid in, and the interstitial osmotic pressure pulls the fluid outside. So the gradient of this determines the fluid. Hope this is clear to you. So let us look into the values. The capillary hydrostatic pressure, remember, approximately 30 millimeters of mercury in the arterial end. So this is the capillary. The arterial end of the capillary, the pressure is somewhere around 30 millimeters, and the venous end, it is around 10 millimeters of mercury. As mentioned, the interstitial hydrostatic pressure is -3. Capillary osmotic pressure is around 25 millimeters of mercury, and interstitial osmotic pressure is around 5 millimeters. The gradient of this determines the fluid, how the fluid is maintained inside the capillaries. The gradient of these two determine how much fluid is going into the interstitial space. Hope this explanation is clear to you. Now we look into the pathophysiology of edema. We have already mentioned the mechanisms. So this here again you should remember, the increase in hydrostatic pressure as occurs in congestive heart failure, decrease in the osmotic pressure as occurring in nephrotic syndrome because there is hyperproteinemia, increased capillary permeability as occurs in sepsis, in lymphatic obstruction, and when it's too much of fluid retention. So the basic pathology of edema formation is, one is increased hydrostatic pressure as occurring in heart failure. Hyperproteinemia, as in nephrotic syndrome, the osmotic pressure is less, so the fluid cannot be maintained inside the vessels. When the lymphatics are obstructed, as in lymphedema, due to filariasis or radiation therapy, Candida again produces edema. And in cellulitis, what is happening? There is vasodilation, inflammation, the various cytokines. So increased vascular permeability is the reason. So the various mechanisms we are discussed. Now we look into, so depending upon the regions affected, sometimes the edema can be predominant in the face, the periorbital region, classically seen in renal problem. Sometimes in angioedema again you can get on the face. You can get dependent edema, classical example the cardiac failure, but can be generalized edema. So various types of edema we can get. The most important is the dependent edema that occurs in heart failure. We can get unilateral edema when there is, for example, is deep vein thrombosis, or somebody has varicose veins. So unilateral edema can also occur. So types of edema as mentioned, it can be generalized edema, localized edema. Depending upon the distribution, you divide into periorbital edema. If in the abdomen, it is ascites. So basically remember this. So again, for a few more pictures, you can see this is the typical appearance of renal edema, periorbital edema. When there is a outer proportion, abdominal distension, it is liver disease. And you can get the pitting edema, classically seen in heart failure and also in patients with the hyperproteinemia. Now we look into what are the clinical features. Again, we divide into generalized, localized, pitting, non-pitting, whether it is tender, non-tender. So tender edema, you get an inflammatory edema. Distribution I already mentioned, periorbital and renal, dependent in heart failure, as it is in liver diseases. Hope this distinction is clear to you. Now we go into the main causes of edema. So you can remember, one is by using chalk. C is for cardiac failure, in H is for hepatic disease, A is for allergic angioedema. for inflammatory conditions. L is for lymphatic. For MCA, breast mastectomy, radiation therapy. K is for kidney disease. And why in heart failure you get edema? Just you look into the reason for edema in heart failure. So when the heart fails, end diastolic volume and pressure inside the ventricles increases. So for example, here the thing that the right ventricle is failing. What will happen? Right ventricle is unable to pump the blood properly. So there is increase in the end diastolic volume and pressure. That will be transmitted to the right atrium, and that will be transmitted to the superior vena cava and the inferior vena cava. So what happens? You get elevated JVP, which is the first sign in heart failure and the last sign to disappear. The pressure inside the inferior vena cava increases. That is transmitted to the hepatic veins, and the liver is here. So what happens? You get a tender hepatomegaly. And the hydrostatic pressure inside the inferior vena cava increases. That leads on to dependent edema. The same way the things will happen in the left ventricle also, which leads on to increase in the LA pressure. That leads on to increase in the pressure inside the pulmonary venous system. That produces transudation of fluid occurring into the alveoli, producing pulmonary edema. Hope this mechanism of edema in heart failure is clear to you. It is increase in the hydrostatic pressure. Again, remember in liver disease, you can see the outer proportion, the abdominal ascites is the dominant symptom in liver disease. Again, you can see the abdominal distension, ascites. And in heart failure, I already mentioned the elevated JVP is the first sign to appear. So whenever you get dependent edema, look at the neck. If the neck veins are not dilated or not distended, no elevation of JVP, there is unlikely to be, or it is not heart failure. The reason is different. So I will repeat once more. Elevated JVP is the first sign to appear in heart failure and the last sign to disappear. So remember this. Now we go into the history taking. We should ask about the onset, duration, symmetry. Always ask associated symptoms. In heart failure, you get dyspnea, chest pain, palpitation, etc. Frothy urine is characteristic of proteinuria. Ask about jaundice, it suggests a liver disease. Medications are important because NSAIDs, calcium channel blockers, obstetric history, because pregnancy associated edema can occur. So now this is a very important thing. Do you remember there is a periorbital edema? This can be inflammatory edema, or the most important thing is angioedema. Angioedema can occur as a part of allergy or anaphylaxis. Two drugs, remember, ACE inhibitor and ARB, notorious to produce angioedema, can occur following bee sting, etc. So one important condition that you should not miss. Anybody can make a guess? This is hypothyroidism. Hypothyroidism, the extreme stage, that is mixed edema. Before that, the patient can complain of pedal edema. So remember, hypothyroidism, you should not miss it. Then another interesting type of edema is the pretibial mixed edema. It may even imitate elephantiasis, that is seen in Remember, it is hyperthyroidism, not hyperthyroidism, that is the pre-tibial mixed edema. So, now the important point to be remembered is what medication commonly causes bilateral angular edema in hypertensives. Of course, heart failure can produce, but in heart failure, the JVP will be elevated. So, if the JVP elevated, again, the most important cause is the calcium channel blocker, amlodipine. Any calcium channel blocker can produce, but one of the most commonly used drug is amlodipine. So, remember this point. In the physical examination, we will be looking at the general examination for pallor, jaundice, which suggests liver disease. Examine the vitals. Look at the JVP. That's one of the very important thing. Examine the heart for murmurs, respiratory system for crackles, pulmonary edema you can get. Abdomen, look for ascites, extremities, look for the skin changes, pitting, pedal edema. So pitting edema in heart failure is a dependent edema. In bedridden patients, it will be seen in the sacral region. And what investigation confirms nephrotic syndrome? Urine protein more than 3.5 grams per day. Of course, there will be hypoalbuminemia and sometimes this hypercholesterolemia can also occur along with it. So the various investigations that should be done are the complete blood count, ESR, CRP, urine analysis, blood urea, creatinine, electrolytes, LFT, TSH, ECG, echo, and a Doppler study, and we are suspecting lymphedema. Think about the lymphatic lymphoscintigraphy, etc. So, in the clinical comparison, remember in heart failure the edema will be more in the evening hours. In renal failure it is usually more in the morning, puffiness of face. And in liver disease, usually the ascites predominates, less of edema. Other clinical features depending upon the investigations we have already mentioned. In the liver disease you can be getting abnormalities on liver function, and in renal disease the renal function will be abnormal. Cardiac diseases will be abnormalities in the ECG, X-ray chest, etc. So the cardiac cause, leg edema more, JVP, and response to diuretics. Renal periorbital edema, proteinuria, hypoalbuminemia. Hepatic ascites, albuminuria, low albumin. Lymphatic is non-pitting, maybe unilateral. Why the lymphatic edema is non-pitting? Because lymph contains protein, and protein will facilitate fibrosis. That is why the lymphatic edema it is. So we'll go to a clinical case. 45-year-old man, bilateral leg edema, breathlessness, raised JVP, cardiomegaly in X-ray, it is congestive heart failure. Very simple thing to remember. So one peculiar type of edema is the pulmonary edema. Again, pulmonary edema is when the left heart fails, the venous pressure increases, there is translation of fluid occurring. So pulmonary capillary hydrostatic pressure, when it rises more than 25 millimeters of mercury, the filtration exceeds the lymphatic drainage, fluid accumulates. So again, it's a transit. Cardiogenic pulmonary edema is a transit. In contrast to ARDS, which is a non-cardiogenic pulmonary edema, and you'll be getting X-ray findings, the butterfly, the classical butterfly appearance, and there can be cardiomegaly also. So that is a pulmonary edema. So the take-home message: understand the Starling forces, take a good history. Key tests are urine protein, albumin, echo, and brain natriuretic peptide if you are suspecting heart failure, and differentiate based on the clinical clues. And I'll end with a quote from MacLeod: Edema results from an imbalance between hydrostatic and osmotic forces across the capillary membrane and the failure of lymphatic drainage. So remember, this is the arterial end of the capillary and this is the venous end of the capillary, and remember there is lymphatics. So the hydrostatic pressure, the osmotic pressure and the lymphatic drainage all are important. Hope this session was useful to you, and when next time you see a patient with the field edema or generalized edema or localized edema, remember these things. Hope it was useful.